Well, hello, my name's Amanda Moyer. I'm a Med-Peds Rheumatology Fellow at Stanford University, and I'm excited to present this case when meningitis strikes twice. Now, I picked this particular case for several different reasons. One, it's very interesting. Two, I think it demonstrates some near pathognomonic findings that we don't always recognize in this particular condition. And three, it really highlights the importance of a really good physical exam and history. And that history might include needing to dig back in the records 15 or 10 years to really get good information, and also talking to family members or people who are close to the patient to really understand what's been going on. So our case starts with a 51-year-old male who was admitted to the hospital with altered mental status with a progressive encephalopathy. He also had fevers that had been off and on for several weeks and a headache. So we were able to find a little bit of past medical history from a chart review, and it turns out that he had been admitted to the hospital at age 38, also with headache and fever, and was diagnosed with a lymphocytic meningitis at that time. He was in the hospital for about 2 weeks at the age of 38 and was treated with IV antibiotics and was ultimately discharged home. Around that time, he also started to develop these skin boils, and that's really the only information that we could find. At the age of 40, he was diagnosed with Weber-Christian disease, and this was based on his recurrent fevers and a biopsy that showed a neutrophilic paniculitis. Throughout his lifetime, he had been treated for this with various things, so NSAIDs, dapsone, varying degrees of prednisone or steroids, and also some TNF inhibitors intermittently. From a social standpoint, he was born in Mexico, but had lived in the US for about 3 decades. At one point in time, he had been diagnosed with latent tuberculosis, but he received the appropriate treatment for that. Moving on to exam, so this was a well-developed Hispanic male, actually quite muscular, but speaking in either one-word sentences or just repeating, I don't know, to anything that we were asking. He also had a very atypical childlike demeanor and labile affect as well. On neurological exam, he had choreiform activity in one of his hands. He had dysmetria on finger to nose testing, and he had an expressive aphasia with dysdiakinesis and ataxia. He had oral ulcers that we didn't find documented anywhere else in the chart, but multiple all throughout his mouth, and we couldn't really ask him at the time if they were painful or not. He also had some cervical lymphadenopathy, and then in terms of skin lesions, he had these scattered erythematous pustules all over his body with some form nodular lesions that may have been tender to palpation, we weren't quite sure, on his lower extremities. So our initial lab work was actually quite reassuring. So his white count was only minimally elevated. His ESR, CRP, again, just minimally elevated. Electrolytes and everything like that was within normal limits. He underwent a pretty extensive infectious disease workup, all of which was negative, normal, or reassuring, except for the interferon gamma release assay, which as expected was positive given his history of latent tuberculosis. His CSF studies were a little bit more remarkable. So his white blood cell count in the CSF was quite elevated at 273. And you can see there was a neutrophil predominance, but also lymphocytes. It was quite pleomorphic. Probably the most interesting finding in his workup were the imaging studies. So he had a CT head that showed hypodensities at the bilateral internal capsule, left thalamus, and midbrain, and also in the pons. And there was almost an expansile lesion in the pons seen on CT. There was moderate volume loss in the left cerebellar hemisphere, We went on to get an MRI, which also showed some pretty diffuse findings. So there were multifocal nodular rim-enhancing lesions with restriction diffusion all throughout. But where we saw the most changes were more in the midbrain area. And that is highlighted by a lot of these arrows too. So the ring-enhancing lesions, of course, makes everyone concerned about infection, but there's actually quite a wide differential for rim-enhancing lesions in the CNS. So kind of case continued. And here's where I think it's really important to get a good physical history. We were able to talk to family and also dig up some charts from about 20 years prior on this patient. So when we talked to his wife, we figured out that way back when he was 38 and hospitalized, actually the thing that got him better was an oral course of high-dose steroids. And we were actually able to track down that prescription in the EMR, so we know he got it, but he was not giving any steroids in the hospital at that time. And the wife was very adamant that that's what made things better. We also found out that anytime he got a new tattoo, he developed zit-like pustular lesions all where his new tattoo was. And most recently, it was 8 months ago, he had a sleeve tattoo, all with pathergy changes afterwards. So we ended up diagnosing him with Behçet's, specifically neuroBehçet's. And we were also able to find these skin lesions from 7 years prior, which quite clearly shows lesions consistent with meningitis and pathergy, as well as more like erythema nodosum lesions. We treated him with IV methylprednisolone, and he had a great improvement, pretty stark, within hours of getting that medication. We also treated him with infliximab before he left the hospital and continued him on that medication with a steroid taper outpatient. So, kind of some take-home points about neuroBehçet's that I really learned from this case is, you can have CNS involvement in 5 to 10% of cases. And I think a lot of us think about blood clots and thromboembolism, but that is actually not the most common manifestation of neuroBehçet's. It's brainstem involvement, much like our patient had with those rim-enhancing lesions, is nearly pathognomonic for neuroBehçet's. And you usually see MRI findings in the mesodiencephalon, so the pons, the medulla, exactly like our patient had. And interestingly enough, Behçet's is very, very, very rarely, like you should consider a different diagnosis, diagnosed after age 40, especially neuroBehçet's. But kind of going back and looking at this patient's presentation, you realize he's kind of had this since he was a young adult. And thank you for your time.